Okay, so gastrocnemius and soleus are the calf muscles, and they're the muscles that take up most of the posterior or calf of the leg. And I think you all know that gastrocnemius is the superficial one. So in this posterior view of the person, in a lot of people, you can actually see both heads of the gastrocnemius. Like bicyclists are a great example of folks who have super well-developed gastrocnemiae. So you can see here these two heads, lateral and medial, and even see right where they come together with that soleus. So that's our superficial one, this gastrocnemius with two heads. And then deep to gastrocnemius is soleus. And as is the pattern of many muscles where you're looking at the superficial versus the deep, our superficial one crosses two joints. Here we've got the gastroc crossing the knee as well as our ankle. Whereas the soleus, it's shorter and deeper, and it does not cross the knee, but it does cross the ankle. So our gastrocnemius passing on the posterior aspect of the knee, when it shortens, what action would it have on the knee? Anybody?
Flexion.
Thanks. Then both gastrocnemius and soleus, very powerful plantar flexors of the ankle. And as we pointed out earlier, and some of the videos do a great job of this in your module as well, this is a very powerful movement, and you can actually stand on your tiptoes, in effect, raising your entire body weight. So big, strong muscles, you use them, every day. Everybody does, even obviously just in walking. But of course, dancers and runners and bicyclists all use their gastroc and soleus quite a bit. Questions so far? Okay, so let's look into the details a little bit more here. It looks like this particular picture, we can see, what part of the gastrocnemius and soleus we can see from the anterior and lateral views. So you could still see part of them. And as we talked about earlier today, even when the client is supine on the table, is a great time to massage those two muscles. I love these cross-section pictures. Trail Guide does a great job of these. And in these cross-section pictures, you can see where the gastroc is. And here we have the calcaneal tendon. And here we have our deep soleus. Now, the lower leg, we'll get into this some more sections of it we study, but the lower leg is very interesting because it is divided by thick fascia into discrete compartments. And this becomes clinically relevant because with those thick fascial divides between the compartments, there isn't much room in the lower legs for inflammation. And so, believe it or not, it can actually become an emergency situation. If somebody has too much inflammation, it can become acute compartment syndrome. And sometimes they actually need to, cut some of the fascia to allow for some space there. And we'll look at the other muscles later, but we're going to stick to gastroc and soleus right now. I think this view right here on the left is great to show really what part of soleus is very palpable. So of course soleus is a lot of it is deep to gastrocnemius, and you know, just like pec minor, if you're to press pec major, you know, into pec minor, yeah, to some extent you can, you know, you're pressing into pec minor, but if you really want to isolate it, you know, you want to go around pec major. And similarly for gastrocnemius, where we can really feel the soleus is more on the distal aspect and then on the more lateral aspect. So here, this white part is the calcaneal or Achilles tendon, two names for the same thing. And then right in front of here, we really can palpate and release soleus. And for many folks, this muscle is very tight. Great muscle for focus. And of course, here we have our synergist page, and we talk about how gastrocnemius and soleus are very strong plantar flexors, and here are the other muscles that help with that: our tibialis posterior, our peroneals, longus and brevis, and our flexor digitorum longus and hallucis longus. So the lower down on this list we get, the weaker the action becomes. So these first three really are our strongest plantar flexors. All right, so breaking down the origin, insertion, and action. First looking at our more superficial muscle. Our gastrocnemius originates on the condyles of the femur on the posterior surfaces.
Zefire, you've got gray boxes. Oh, well, now the one that was covering everything disappeared.
Oh, okay, thank you. Sorry, was that going on for long?
The ones at the top were, but the one that was covering everything on the picture was only there for a second, just long enough for me to open my mouth and say something, and then it disappeared.
Oh, good. Thanks for letting me know, because yeah, sometimes it looks different on my end. Does that move the gray box a little better?
Yeah, there are no gray boxes there anymore.
Excellent, thank you. All right, and our insertion is the calcaneus, which again, of course, is our heel bone. And it's via the calcaneal tendon. And the calcaneal tendon is the same thing as the Achilles tendon, two names for the same thing. And it's a super powerful tendon and very palpable. And I'm kind of drawing the borders of it, but it kind of comes up here, you know, where the two heads of the gastrocnemi are. So this, both heads of the gastrocnemius and the soleus both pull into this calcaneal tendon. Now, you know, tendons don't release in the same way that muscles do, but you can still, there are still some contractile fibers in there. There are some, you know, this is going to cause some proprioceptive signals to work with tendons. And so the calcaneus is one where you can do a little bit of Golgi tendon organ release, GTO, where you can either, you know, take two sides of the tendon and then put it into like a U shape where you push your thumbs up and pull your fingers back, or you know, put it into an S shape. And you just hold it for, you know, 15, 30 seconds. This one doesn't feel amazing. It doesn't feel bad, but it just helps work with the proprioceptors to help release. And a lot of times there's a lot of the nerve, you know, signals right here at the musculotendinous junction as well. And there's a great acupressure point there as well. Let me try to erase that. Okay, and then our actions are pretty straightforward. I think I think these two muscles ought to be quite easy to learn. We are attaching posteriorly to the knee. We can flex the knee, and posteriorly to the ankle, we can plantar flex the ankle, the talocrural joint. So any questions on the gastroc? But we've been massaging this one all the way since like the second or third week of school with our compression, and then into Swedish with our petrissage. You've probably noticed that, sometimes folks will have more hypertonicities or adhesions or fascial constrictions in one head versus the other. So, really take your time to feel what's going on with both sides as you work those. Oh, I wanted to say one more thing about the calcaneal tendon. I first mentioned Golgi tendon organ release and then working the musculotendinous junction. But also, things can really get bound up on the edges of the tendon. So it can be worthwhile to do some linear friction and even some MFR on the borders here. Achilles tendon tears are somewhat common, so I'll mention them at this point. Sometimes folks get a minor tear in the Achilles tendon, which sometimes is not a huge deal, but the tendons, as well as ligaments, they're both made of the same kind of dense, regular connective tissue. Both of them have much less blood supply than the muscle tissue. And you could even say they're avascular. So if they have less blood supply, that means they're going to heal a lot slower. And in some cases, they don't really ever heal in quite the same, with quite the same strength that they once had. So with more of a, a bigger tear in the Achilles tendon can be, an ongoing issue for the person. And then, of course, a complete tear would require reattachment. All right, so very straightforward on that one. Now we're taking a look now deep to gastrocnemius, to our soleus. And you can see the lighter grayer areas here in the center, that's more of the tendinous tissue. And then our bellies here are more on the outskirts. And this is a typical arrangement for deeper muscle, to kind of have that tendon in the middle. So our origin, as I mentioned before on this one, does not cross the knee. And we're here at the soleal line. And that is too deep to palpate. That's just, sort of a demarcation for learning the muscle. You're not going to palpate that deep. And the posterior surface of the tibia. So again, these are the, and the head of the fibula. And you can palpate the head of the fibula. I got a little messy with my shading there, but on the lateral aspect. And of course, this is more on the proximal aspect of the bone. Questions on that one? And then our insertion, sorry, I didn't really pause long enough. Further questions? All right.
No questions.
Okay, thanks. And then our insertion is the same as the gastroc, so we're sharing the same tendon. The calcaneus, of course, our heel bone, via the calcaneal tendon, our very big, strong Achilles tendon. And then we have just crossing one joint, our talocrural joint. And we are very strong plantar flexor with this muscle. So pretty straightforward on these two. And again, you can definitely palpate and massage the soleus, but it is on these lateral distal aspects that I'm shading in blue right now where if you get to the edges of gastrocnemius, you can palpate soleus. And it comes up very often that folks, gastroc and soleus are tight. So you definitely want to warm up the gastrocnemius and fascia first, but then you definitely want to check and see how that soleus is, and don't leave that out. And sometimes it, is really lacking in a good, rich blood supply. If there's been some, chronic hypertonicity and or old injuries, so you might feel a kind of a dry, kind of a maybe brittle is too strong of a word, but there's a dryness that you can often feel on some of these muscles. So you'll want to bring in some circulation with your Swedish and other circulatory techniques, and then it can be very valuable to do some very focused, deep work on those muscles.